We'll go ahead and get started. Hello to everyone joining via Zoom. Great to have you. It is my pleasure to introduce today Dr. Medina-Marino, who is a principal investigator at the Desmond Tutu Health Foundation in South Africa. Dr. Marino is spearheading the establishment of a new research site in Eastern Cape Province. And he's also the co-leader for the Foundation's Division of Men's Health. He also has an honorary associate professor position in the Department of Medicine in Cape Town, University of Cape Town, and an adjunct associate professor in Department of Psychology and University of Pennsylvania. Dr. Medina-Marino maintains a very highly active research portfolio around men's health, including context of TB, HIV, and mental health. And we're very excited to hear from him today on his work on TB, case finding, and interventions. Just to say that his funding comes largely from the National Institute of Health, Bill and Melinda Gates Foundation, and the Foundation for Innovative New Diagnostics. So welcome very much. Excited to have you. And I'll hand it over.
Great. Thank you very much. Maybe it might be. Should I?
Yeah, you can stand wherever you.
Okay. I might be standing off camera then, so I don't block.
Oh, okay.
Yeah.
Well, you will just you, so you
Okay.
can stand wherever.
Okay, so first off, thank you all very much for inviting me. I lived in LA for about 8 years, and so it's always nice to come back, and I haven't been back since I left in 2009. So it's great to be back. Yeah, so today I'd like to just tell you about some of the work that we're doing on men's health in the context of TB. I know that originally the announcement said men's health and TB and HIV prevention, but as I was going through the presentation, I thought, let me take that HIV prevention part out because it was getting a little bit too long. But anyway, so okay, just before I start the whole talk, I'm sure most of you know about South Africa, but for those who might be online who haven't, let me just give you a quick orientation. So obviously South Africa is at the bottom of the continent. It has nine provinces. This is a map of provincial map of South Africa. Okay, so South Africa is unfortunately the global epicenter, or one of the global epicenters for both TB and HIV. For TB, the general population prevalence is 737 per 100,000. So that's quite a large number. Among those 15 years and older, it goes up to as high as 825 per 100,000. 58% of TB patients are living with HIV, and a recent analysis showed that, unfortunately, about only 50% of all individuals with TB actually complete their course of treatment. With regards to HIV, obviously, it has one of the highest general population prevalences in the world at about 14%. Amongst those 15 to 49 years, it's about 20%. 7.9 million people have HIV in South Africa, making it the largest absolute number of cases of HIV. And of those, only about 4.8% are on ART. So that's 90, 90, 90, or 95, 95, 95, whichever year you're wanting to talk about. There's still work to be done on the cascade. Though, before I really jump into the talk, obviously, you know, the history of South Africa with the racist apartheid regime really impacted the allocation of resources. So typically when people think about, oh, where's all the great research in South Africa coming from? It's always Durban, Johannesburg, Cape Town. And I point this out because we specifically work in Eastern Cape Province. So Eastern Cape has the lowest human index score of all 9 provinces in South Africa. Its HIV prevalence is the second highest at 25.2%. The TB prevalence amongst those 15 years and older is hands down the highest in the country, is about 1,236 per 100,000. So that's just a whopping number. It has some of the poorest outcome metrics for HIV, TB, mental health, maternal child health, and there's definitely minimal research infrastructure, which I'll come back to at the end. Okay, so the Desmond Tutu Health Foundation started the research site there in about 2017 is when we got a grant and we were able to move activities there. The Desmond Tutu Foundation sites have typically been associated with Cape Town. So the ability to bring in an organization like Desmond Tutu Foundation really is trying to help catalyze more research infrastructure in partnership with local universities. So ultimately, DTHF wanted to move to Eastern Cape, really because of some three main reasons. One, the voices of citizens and communities, especially in the context of HIV and TB clinical trials, are hardly ever heard of. Because why? All the clinical trial units are always Durban, Johannesburg, Cape Town. Another reason was to ensure that key public health issues are researched to ensure targeted interventions, and then also to work with the province to provide them key information to target their resource allocation. So inherently very altruistic, though in the context of being a little bit more selfish, because Durban, Johannesburg, and Cape Town are so saturated with research, being able to work in a more research naive area of the country definitely allows for much faster expansion and supports. Okay, so TB, both globally and in South Africa. So TB is hands down the leading cause of death globally from a single infectious disease, and unfortunately took that spot back from COVID within the past few months. In 2020, there was an estimated 10 million people who developed TB. There were 5.8 million cases diagnosed, which is down from the 7.1 million in 2019. And all of these, changes for the worse are all due to COVID. 1.3 million people that were HIV negative died from TB, up from 1.2 million previously. 240,000 people died with TB and HIV, up from 209,000. And 4.2 million cases of TB were not diagnosed or reported by the health system. And this is typically referred to as the missing cases, which we like to say these cases aren't missing, because it's more the health system is missing them. Okay, so quick picture of TB incidence globally. So obviously this is a map of a global map with different colors showing different incidents in countries. Those highlighted in yellow are countries that have very low incidence of TB, either countries or regions. And those highlighted in the red circles are those areas that have very high incidence of TB. So just to give, especially within the US context, just an idea of what's going on globally in the US and then in South Africa, this gray line here represents the incidence of TB between 1990 and 2019. The global incidence has decreased from approximately 161 to about 130. So it's a very slow decline. When you talk about what's going on in the US, currently it's about 3 cases per 100,000. When you talk about South Africa, it is a very huge difference. So I like to point this out because, visually it's a very easy graph to tell there's something definitely going on in South Africa. Obviously, the curve of the increased incidence of TB really does mimic the increase in HIV prevalence in the country. And where it starts to go down in 2007, 2008, 2009, really is speaking to the national rollout of the ART program. So, in the years between 2000 and 2009, really TB was just taking off, all because of the co-infection rate with HIV. But South Africa still hasn't gotten back down to where they were in 1990, which was just over 200 cases, 250 cases per 100,000, which is still high, but definitely not the 1,200 that we saw nationally. Okay, so one big thing that these curves mask are TB significant gender disparities and the large proportion of missed cases. So these are the 2 topics that I'm going to focus on for this talk. So globally, the burden of TB definitely rests upon men. In 1998, the WHO Global Health Report actually showed this data, but it wasn't until 2013 that they actually had words saying, hey, men have a higher burden of TB compared to women. In 2019, adult men accounted for 56% of all global cases, adult women for 32%, and children 12%. So this is very much the flip of what we see, at least within the context of HIV in sub-Saharan Africa, where 63% of the cases recently are amongst women. So, okay, when we talk about the global, when we talk about the global notification based on age and sex, and where we see the gap in the number of cases notified versus the number of cases estimated, we see that there's a huge gap in reporting between men and women. So when you look at this graph, the white rectangles represent the total estimated cases. The colored parts, green for men, purple for women, represent the number of cases notified. So you could see that the gap in the number of cases that aren't notified but are estimated are much larger for men compared to women. So about 70% of all cases that are missed by the health system are amongst men. This also speaks to the fact that women are probably accessing diagnostic services more effectively than men are. Men are definitely not benefiting from the gender equity or global gender transformative responses that are part of the global discourse around global health. And this definitely speaks to the need for strategies to improve access and uptake amongst men. Just to drive home that it's not some sort of a few country outliers that are really dragging this to make it look like men are at higher have a higher burden of TB. So between 2007 and 2018, a number of countries did their national prevalence surveys, and not one country showed that women had a higher burden. In Vietnam, there was a whopping 4.9 cases amongst men for every 1 case amongst women, with the lowest being in Ethiopia, 1.2 cases of men with TB compared to women. South Africa falls towards the lower end. It's probably because there's such a high rate of HIV and TB, because women have the higher burden of HIV, that it might equal out or say drag the numbers down a little bit more to what might look like gender parity, but it's obviously still not. Okay, so TB and men's health in South Africa. So TB in South Africa is responsible for a very large portion of the differential life expectancy between men and women, specifically about 81% of the 11.2 life year difference amongst those with HIV, and 43% of the 13-year life difference amongst those without HIV. Men are also more likely to be delayed in their access to testing and initiation on treatment, die while engaged in care, and be lost from care during treatment. In the 2018 National TB Prevalence Survey in South Africa showed that the prevalence amongst men is 1.62 times higher than, 1.62 times that of women. Okay, this graph here shows the microbiologically confirmed number of cases of TB in 2019. This is from the National Health Laboratory Service. So this is national data that is available publicly. So these cases are broken down by gender and age group. Yellow is what we're seeing amongst women. Red is what we're seeing amongst men. But obviously, we always want to have that per 100,000 population because we're public health folks. So when you look at, and again, 62% of these cases are amongst men. When we look at the incidence by sex and age group, yellow again is women. Here's what we see amongst men. So typically, WHO says it's a real emergency if it's above 150 cases per 100,000. So the fact that men are nearing 1,000 cases per 100,000 and women are about between 400 and 500, this is still really quite an emergency. So when we think about the incidence in provinces, because obviously what you see at national level and what you see at subnational level can be very different. So again, when we talk about the historically advantaged areas of Durban, Johannesburg, Cape Town, this is where the overwhelming majority of TB research is going on. Why? I have no idea, and I'll show you why. So when you look at what's going on in Gauteng province, which is where Joburg is, this is the incidence curve by gender and sex. By sex and age group. When you look at what's going on in Western Cape, definitely significantly higher. Unfortunately, a good place to still conduct TB research. What's going on in KwaZulu-Natal. Now here's what's going on in Eastern Cape. Just radically significantly higher. And the difference between men and women, the incidence is much more striking. So within Eastern Cape province, there's a number of districts. So when you look at what's going on in terms of the districts in Eastern Cape province, So here's what's going on in the Buffalo City Metro Health District. This is where East London is. This is where our current research site is. And obviously it looks very cleanly like a bell curve, with a peak at around 35 to 44 years of age. When you then look at OR Tambo district, which is more rural, you see it skewing far older in the life course. When you look at Nelson Mandela district, which is where the city of Port Elizabeth is, you see again, it starts to skew slightly earlier, younger in age. Then when you look at Amatole district, this is again another rural district. It skews slightly older, but there's also this humongously whopping difference between men and women in terms of incidence. And then you see Sarah Bartman district, which is probably the hardest hit district in the country, where for men, virtually all age groups are topping out at over 2,000 per 100,000. So just numbers that just aren't typically seen. Okay, so given the global and South African specific gender disparities in TB prevalence, uptake of diagnostics, treatment initiation outcomes, we were originally trying to figure out, okay, what are the options and what are the interventions out there to improve men's access to care, men's uptake of treatment, access to testing, completion of treatment. And what we did was we started looking through the literature to identify an intervention that might have been done somewhere else and might have been adaptable to our local context. So at that time, there was this great systematic review and meta-analysis that looked at adherence and interventions. They had identified 129 papers, and they had broken their adherence interventions down into a number of specific categories: DOTS, treatment reminders, incentives, patient education. You can see them here. Let me just say off the bat, I am not a believer in DOTS. What the paper showed was inherently DOTS was better than nothing, but everything else was better than DOTS. But there really still wasn't any clinical, none of these interventions really showed a clinical, clinically significant difference. We did a deep dive review of all of the papers that were published here. And what we did was we said, okay, let's just look at the papers after 2005, trying to identify interventions that worked for men, compared the components of those interventions, how they were delivered, and trying to figure out how to optimize these interventions to improve men's health issues with regards to TB. The huge problem with this was of the 129 articles, only 76 were after 2005, not that much of a problem. Problem was, of those 76 papers, only 17 stratified their results by gender or sex. Of those 17, only 13 showed improvements amongst the intervention cohort, but amongst those 13, 8 showed that men did better than the control, but women were still doing better than men. And in another 5, there was no treatment effect amongst men, meaning that it was the impact of this intervention amongst women that really drove the statistical significance in the study. And thankfully, at least none showed that men did worse than the control. So the problem with this is, at worst, this uneven reporting of sex disaggregated results was perpetuating and ignores gender disparities. At best, the poor reporting of sex disaggregated results was limiting our ability to identify an intervention that could be adapted for men. So this resulted in us saying, well, I guess we're going to have to go do some more formative work and inherently try and identify or develop a intervention de novo. So the study that we did here, it had 2 specific aims. One was to investigate how men and women's experiences during TB treatment and care informed and impacted their preferences for interventions. And the second aim was to take this first aim was qualitative. The second aim was quantitative. The second aim was taking all the work from the qualitative work to develop attributes and levels for a DCE, put it into a DCE, and really try and have the quantitative component really inform additionally a intervention. It's mainly the first aim that I'm going to speak to you about. We just finished off all the DCE. We're still analyzing that. So for aim 1, it was a prospective cohort study. We did this with TB patients, those currently in treatment, those that recently completed treatment and those that we had a case definition for being at risk for loss to follow-up. And the way we did that was we said, if an individual was expected to come in on June 1st for their treatment refill, if they missed 15 days from when they were supposed to come in for that refill, we said, okay, these individuals are likely at risk because after 15 days of not coming in, they're unfortunately on that trajectory to potentially being lost to care. Our behavioral framework was a network individual resource model. This was something this was a model that was actually developed for HIV prevention studies. So what we did was we consented individuals and then followed them up until they met one of the case definitions. For those who recently completed treatment, if they were recruited in month 1, we waited until they completed the 6 months of treatment. So all of these individuals were prospectively followed up. We did about 180 qualitative interviews. So this was quite a large data set that really helped inform our next set of work with the DCEs. In addition to interviewing TB patient participants, we also interviewed about 48 key supporters of these TB patients. And then we're also in the process of doing focus group discussions. So quite a hefty chunk of qualitative work here. So just to describe, to give you like a case study of one particular gentleman that was in the study, Odwa is a married man with 2 kids. He works in a scrap metal company near the airport. Odwa started to get sick 6 months ago. In his interview, we asked him how his illness affected his work. And his reply was, mostly it was the coughing. At my work, I work with a blade that's similar to the one that they use in a butchery. So I would be busy cutting a battery with one hand with the blade, and in the other hand, he's coughing. So I did have a bit of a challenge. So Odwa went on to explain how he was not able to do his work safely, and he actually lost his job as a result. He went to the clinic and was diagnosed with TB and immediately started treatment. The treatment had been difficult for him since the pills made him sick, and he didn't eat at the same time. His family didn't eat at the same time as he took his pills, so he felt lonely and wanted to speak with another man who had TB. He thought that this man would be able to understand what it means to be sick while having responsibilities to provide for his family. And he said that this other man could help remind him to take his medication since it was so new to him. So this is already starting to speak to the interest in a peer-to-peer support intervention, which the other 90 interviews with men continue to bear out. So again, with all the qualitative work, we were definitely picking up peer-to-peer support. These are some representative quotes. I'm only going to read to you the ones that are highlighted in the yellow box. So one gentleman said, I would show them myself as I have walked the same path, meaning he experienced TB. It was not easy taking the treatment, but I would show the friend a living example, which is me. I have completed treatment in front of him and pray that I will be a better example to him since I also come from the same situation. I have swam and crossed, and he also can swim across. So another aspect of men's preferences for an intervention is for the intervention to be delivered in male spaces. One gentleman specifically said, they're near the community toilets because that's where men are normally found sitting and playing dice. Even if you come and stop here, and since you would know me, my brother, it will be easy to come and start a conversation, and a lot of people will listen. So men also reported feeling isolated from their families and communities during TB treatment and advocated for community awareness to reduce their isolation. One gentleman said, it is embarrassing to go to the next door neighbor and ask for food. Maybe there are a lot of people who want to take their treatment, but there are things that they wish they had but don't. So they end up not taking this treatment. I don't have necessarily the data here, but one of the things that continued to pop up was the impact of TB treatment on food security issues. And so there were kind of 2 issues that we were able to map out. One was obviously the men and women who needed to take food with their treatment because it upset their stomach, completely understandable. The other part was, it seems that a lot of men And less so with women, but a lot of men were saying that the treatment makes them very hungry. So the increase in appetite caused them to need obviously more money to buy more food. And because a lot of these men were already not working very typical standard jobs, that increase in needing to buy food was putting them at a disadvantage, and it impacted their food security. So almost these two kind of distinct pathways for how food plays into treatment outcomes. Okay, so the next part I want to talk to you about is comparing and contrasting women's experiences during TB treatment. Both men and women anticipated changes to their social networks and anticipated negative comments and judgment regarding their TB-related symptoms. So instead of just reading off the slide, let me tell you what we were seeing. So even though we were trying really much to focus on preferences for interventions and general experiences, we didn't necessarily ask specific stigma-oriented questions in this, but the impact of TB-related stigma kept jumping out at us. Now, both men and women were saying that they anticipated stigma, and that both men and women were speaking about how they felt isolated during TB treatment, but the unique thing that we always have to be thinking about with regards to stigma is, sure, there might be gender neutral ways that, or gender neutral, how am I trying to put this? Sorry. There are gender neutral stigma acts that men and women will speak about. Specifically, let's say with isolation, but the mechanism by which that stigma is actually impacting their behavior, we're finding very distinct gender differences. So a good example is both men and women were saying that they anticipated stigma. And again, they both spoke about feeling isolated, but how they became isolated due to the stigma was very different. So women spoke about being isolated or isolating because they were concerned about transmission in the household, infecting family members, and they also spoke about self-isolating as a way to ward off experienced stigma. So they were concerned about gossip. Men also discussed gossip, but it wasn't the impact, it didn't impact their isolation. What men spoke about in terms of how they became isolated was men anticipated stigma, but it was the experienced stigma of when they actually finally did disclose to family and friends, it was their family and friends who actually isolated them, whereas women had preemptively isolated themselves. And so understanding how, in a intervention that might speak to dealing with men and women's isolation, because they get isolated different ways, you might need to think about stigma interventions that approach the issue slightly differently. This one, so in terms of men experiencing familial ostracization, this one that I highlight in red, really did hit us. So this gentleman said that his sister, my sister distanced herself to me because, my sister distanced herself to me when I called her to ask her how she is. And she responded that she is not feeling safe around, she was not feeling safe around me, and I'm going to be affected. And so what the sister did was he went on to talk about how she would lock him in his room when anyone came over. He wasn't allowed to interact with anyone else in the household. And so even though he still had housing security, it definitely impacted, and the stigma experienced from his being perpetrated by his sister was really impactful. And this gentleman, he was currently on treatment, but we followed him through, and unfortunately he wound up being lost to care. And when we spoke to him again, he said it was because he was kicked out of the house. And it all spoke to the sister isolating him. So again, not having that support network, men seem to be more isolated by family members, whereas again, women seeming to self-isolate to protect others. So again, the idea of these gender neutral and specific stigma experiences, again, men were more often forced into isolation by their social network. Men were more likely to express a sense of social loss. And a few men gave examples of familial ostracization, whereas women showed higher concerns for negative judgment and often pre-isolated themselves to avoid gossip or community judgment. Okay, so that was our work with TB in men. I want to talk to you now about our use of a portable diagnostic tool to do active case finding in the community. So obviously, cases that are missed by the health system are a key driver to transmission. So obviously, the individuals go on without treatment. Of the estimated 10 million individuals with TB in 2020, approximately 4.2 were either not diagnosed, not treated, or not reported. And to minimize missed cases where TB prevalence is greater than 100 per 100,000, WHO suggests systematically screening individuals, especially those seeking care or in a healthcare facility, and specifically vulnerable individuals. So factors associated with missed TB cases are obviously in individuals' health-seeking behaviors, also structural barriers, access to health services and testing, insufficient diagnostic sensitivity, especially for those with HIV, and the health system's failure to identify individuals presenting to their clinics. I'm not going to present it here, but we did a study a few years ago looking at the magnitude of missed cases who are actually presenting to the clinic, either because of a TB-related symptom, cough, fever, night sweats, weight loss, or they presented to clinic either for some other health ailment or accompanying people. And on any one day, the system was missing about 80% of all TB cases that were coming in and out of the clinic. So obviously these individuals, you would assume that they're going to be missed at some point, but the fact that they're in the health system, in the clinic, being missed either because they were not screened, or we found a number of cases where they were screened, but for some reason they were not tested. Again, the similar image that I showed you before about the gaps in TB case finding in South Africa, again, you see men have higher gaps of not being identified with TB, those missed cases by the health system. And again, Eastern Cape has by far the highest proportion of estimated cases missed. But again, most of the active case finding studies are happening where? Durban, Johannesburg, Cape Town. So again, just a huge missed opportunity for historically not doing more work in Eastern Cape. Okay, so active case finding has been shown to improve early case detection and improve outcomes. This is one form of this is screening of household contacts of TB index patients. A huge problem with active case finding when you do household contact investigations is the proportion of individuals who do not present to the clinic after being given a referral. And in some studies that we've done, we're finding only about 20% of individuals who are given a referral for their symptoms ever present to the clinic. So this not only speaks to an ineffectiveness of active case finding in this context, but also the huge cost if South Africa were even able to do this, which they can't because of its resource incentive, but it would almost argue that this shouldn't be cost effective. And obviously the idea that home-based testing may improve early case finding and linkage care. So that was ultimately our idea that, if there is poor uptake of, screen at the home, refer for testing. If we could do the testing in an individual's home, it takes out that whole step. And the hope was, well, if you provide someone with a test result in their home, would it increase their uptake of that referral for treatment initiation? So there were two studies that make up this body of work. One was NIH grants back in 2016. Another one is a FIND study that was more recently funded. The study is being done in the Duncan Village informal settlement area. This is a very high prevalence area in East London, and we did this in about 10 clinics. Okay, so the two devices that we used, one was a Gene Expert 1 device, and the other one was the Omni device. So some of you may know that the Omni was taken off the market for reasons I'm not going to go into. In our original study, we used this adapted GX1 device, which we hooked up to, or we jerry-rigged to an external battery. The second study was using the Omni device, which had an integrated battery, much easier to lug around, But again, Cepheid took it off the market before they even released it. We were one of only 2 groups to actually get a handle on the device before they took it back. Okay, for this first study, it was a pilot randomized control trial. This was testing individual household contacts of TB index patients in their home. The intervention was you screen at the home and test if someone has symptoms and then refer for treatment, whereas the control is the typical screen at home and refer for testing. We use sputum, which is the standard. The next study, we use a different specimen. Okay, so again, this was a relatively small study. We had identified 282 TB index patients who listed a total of about 1,070 household contacts. We screened 906, so that was a pretty good household screening rate. Of those that were screened, 507 were 18 years and older. Of those, only 100 screened positive. All individuals under 18, because they're children, we just immediately referred for additional evaluation at the clinic. Of the 100 that were screened, 98 consented. It was at this point that we said, would you be willing to let us test you in the house? And that was an indicator of acceptability. So all 98 said yes. And then we randomized those for intervention versus control. This is just an image of the setup in an individual's home. Okay, so let me get to this side actually. When we look at acceptability and feasibility indicators, so obviously 98% of individuals consented, so this speaks to the acceptability of being tested in their home. Of the 51 individuals randomized to the intervention arm, all 51 attempted to provide sputum, which would be the equivalent if they had gone to the clinic and attempted sputum there. So obviously only about half were able to produce a sputum. So this speaks to the ongoing issue of sputum as the specimen to be tested. When we think about feasibility indicators, we looked at the validity of test results, and 95% of test results produce a valid test result. Again, it's getting into small numbers, 23, but it's still nice to see that we only had 1 invalid test result. That was the very first test we ran, so we chalk it up to inexperience. Okay, so when we look at the TB testing cascade of those individuals with symptomatic, with TB-related symptoms, in the intervention, all 100 inherently presented for testing because we were providing the test in their home. You know, it was sort of a, of course, that's what you would expect. But of the 47 individuals referred for testing, only 7 presented to the clinic. So that's only about 15%. So again, it speaks to the really poor uptake of referrals. When you talk about number of individuals actually tested for TB, 47% in the intervention were tested for TB. This was a limitation of sputum, collecting sputum, and only 12% were tested in the control arm. Of those, the number of individuals who actually received their test results, 95% in the control group, 95% in the control group, 66, in the intervention group, 95%, in the control group, 66%. But again, the portion of individuals actually getting a test, there was a large fall off in that. When we looked at the days from screening to treatment initiation amongst those who had a positive test result, all individuals presented within 1 day. It's an N of 2, you can't really make anything of it, but the next study will definitely improve on this, as I'll show you. For those who were in the control group, it took about 40 days to get them on treatment. So again, a very small study, but it definitely showed that it's acceptable and feasible to do home-based testing for TB, which had never been done before because there was never a diagnostic test that you could actually take into someone's home. It significantly increased the portions of contacts who actually tested for TB. It seemed to improve the time to receiving test results. Again, small sample size may improve time to treatment initiation, again, small n, and again, sputum-based testing is a big limitation. Okay, so what we did in this next study was working with a lab-based colleague. He has been optimizing oral swab specimens. Now, this has been seeming all the rave in lots of university labs to try and figure out how to do this. I think I could say I think we've cracked the code on this. The results aren't out yet, but it's looking very good so far. This was a longitudinal cohort. We did not break out into intervention versus control. All individuals were offered home-based testing. Done again in the same community. And this time what we did was we compared home-based sputum collection and testing to pooled oral swabs. So we did both pooled oral swabs. And individual swab testing. The idea of pooled oral swabs is, let's say you go to a house and you have 5 individuals who all screen positive who could provide a specimen to test. If you only have 1 or even 2 devices there, the device still takes about 90 minutes to run. So as soon as you have a large number of individuals in a household, or let's just say more than 2 or 3, the time in the household could get to be 5-6 hours. That definitely is going to start to reduce the acceptability of this kind of intervention. So the idea of pooling swabs is, if you had a household that you could pool and only do one test, and if that test is negative, then you're done with the household, even if you were able to collect 5 sputum. And so this could really improve cost effectiveness, and because the number of households that typically might have someone symptomatic but actually test positive is low, if you're actually testing everyone in the house that could give you a sputum, it'll take a long time and it's not very cost effective. Okay, so in this study, we recruited so we visited, of TB index patients, we visited about 244 households. This 244 households represent 494 household contacts. We consented 192 of the households, which represents 380 individuals. So amongst those 380 individuals that consented, we collected, again, both oral swabs and individual sputum. The oral swabs were taken first, obviously, is to not contaminate, and then we collected sputum if they were able to provide. We also did do sputum induction. So the numbers of individuals able to produce a sputum was slightly higher than what we saw previously. The big takeaway here is testing individual sputum, we were finding a positivity of 12.3%, which is for TB really, really high. When we look at the number of households that had at least 1 individual who was positive, we found about 4.4% of households. So again, it speaks to, if you could produce 1 sample to test using pooled swabs, it's probably going to be more cost effective. So one big thing is, of all the individuals who had a positive test result, which was about 17 individuals, all individuals presented within 72 hours. So 100% uptake over the referral, and all within 72 hours, with the median being 24 hours. So this is quite an improvement. Again, small numbers, but definitely better than N of 2. And it's definitely showing a trend, which one would hope that this is good preliminary data to put into a big grant R01. When we look at the sensitivity and specificity and predictive values of sputum versus the pooled swab, we saw a not very optimal sensitivity, good specificity, good predictive values. But when we looked at individual sputum versus individual swab, we have 100% sensitivity, 99% specificity, very good predictive values. So the last one being when we compared individual swabs versus pooled swabs. So the issue here is probably one of dilution, because the fact that the sensitivity and specificity are so high for individual oral swabs compared to the pool, it definitely says, we need to go back to the lab and optimize the pooled protocol, which is what we've been doing. I don't have those results here, but 2 minutes. Okay, good. When we looked at the results, when we looked at the discordant results between sputum and the pooled oral swabs, we saw that the sputum had either low, very low, or trace detection for the specimen. So again, this helps confirm the likeliness of dilution being the issue why the pooled oral swabs weren't working optimally. And the conclusions here being high acceptability for doing oral swab specimens, high feasibility, high uptake of clinic referrals, and rapid time to clinic attendance without the need for an intervention. So previous studies have tried to do financial or behavioral interventions to get people to present from the house. This was really we're really sorry, yeah, you tested positive for TB, you need to go to the clinic. That's all we did. So there was no behavioral economic nudging, nothing like that. And again, excellent sensitivity, specificity, and predictive values of oral swabs, and poor concordance of the pooled swabs. But again, this was probably an issue of dilution, which we've confirmed that in the lab. Okay, so that's pretty much the end of the science. One last plug, which is more of a University of California Global Health Institute plug, is again, your historically advantaged research sites, Durban, Johannesburg, Cape Town, and the historically disadvantaged Eastern Cape. So we recently put in a D43 training grant with UCGHI. So there's obviously folks in this room now that are part of the mentorship team for that. So the study, the program, what we're calling the Sepile D43. And so obviously this is to train individuals specifically from Eastern Cape and Eastern Cape institutions. The partner institutions of the Desmond Tutu Foundation, University of Cape Town. Right now? I'm sorry?
Is this in review or is this coming up review? I think I'm on a study section.
Oh, crap.
So no, did you say you have UCLA people on it? Because then I'm, okay, that's fine. Then I'm not going to be in the room.
Okay. But, yeah, so this gets reviewed in like 15 minutes.
I'm going to be recused for this particular application.
Okay.
Yeah, so I guess it's okay.
Okay.
But I just, so yeah, I think it was like what next? It's coming up, and yeah, sorry.
That's.
I
was worried about that.
I'm recused.
Yeah. Okay, so just to note, the two institutions in Eastern Cape are University of Fort Hare and Walter Sisulu University, and these two institutions are two of the 8 historically disadvantaged institutions, and these during apartheid times were institutions that were Black only, very poor resources allocated to them, and they have yet to have time and resources to develop a proper research footprint, even within Eastern Cape province. Yeah, so I'll just cut it short. Thank you very much.
Oh,
I'm just glad to say that thank you UCLA for inviting me, and thank you UCGHI, where the Desmond Tutu Foundation is one of the global sites. So we're happy to continue working with University of California. So thank you all very much.
Thank you very much. And thank you to CHIPS for sponsoring this event. I forgot to say at the beginning.
Yes, thank you.
Wonderful. Thanks so much. Really fantastic presentation. A very interesting and a real deep dive into TB and some of the disparities happening in TB and various ways to address it. I don't know if there are any. Yeah, go for it.
Let's see here.
Take a question from the Zoom.
Hi, Emma. Can you go ahead and unmute yourself?
Yeah, hi. Thank you so much for your presentation. It's really interesting because I'm moving to South Africa in 10 days. So I want to know how you got involved in working in South Africa, and what do you recommend for someone getting their master's in public health who want to work internationally?
Oh, okay. How did I get to South Africa? I used to work for the US CDC. I was the laboratory branch chief for them in South Africa. For their PEPFAR programs, and realized that that side of the PEPFAR fence was not what I wanted to do for the rest of my life. So left PEPFAR and CDC, stayed in South Africa. My advice for Are you doing your MPH or you want to do your MPH?
I'm doing my MPH. I graduate in May, and I'm hoping to get into the Peace Corps and working in Lesotho doing HIV and AIDS amongst the youth.
Well, how about this? Let me get your contact information, and then you and I can have a much longer conversation, because I'm happy to talk with you about that.
Perfect. Thank you so much.
Yep.
Any other?
Hey, Emma, I think you had another question too?
Oh, yes. This is just because of what I realized when working in South Africa and in Tanzania doing HIV. I was wondering, how much does stigma play a role amongst men? I know for women in South Africa, there is a big disparity amongst HIV because of the whole blesser situation of women having sex with older men for items. And I was wondering if this is similar in the sense to men, and if the stigma of men being HIV positive is what's making them have more TB.
Okay, so I did present that about 56% of all individuals with diagnosed TB are co-infected with HIV. The recent prevalence survey actually showed that only about 30% of people with TB were co-infected with HIV, which likely says that HIV is not the main driver the way it was assumed to be, and that non-HIV TB is the primary mode of, or individuals that are likely the most, how do I put this? Those individuals that do not have HIV but have active TB are likely the larger concern for community-based transmission than those with HIV. The issue around stigma, so there's been lots of work on HIV-related stigma, much less related to TB-related stigma. A lot of the work with TB-related stigma has been qualitative, which is wonderful, but the quantitative approaches haven't used validated stigma measures. And we actually have an R01 now that is looking at multi-level modeling of the impact of stigma on TB outcomes along the whole cascade, and we're using a lot of validated measures. So can't really say much about that now, but we definitely know that TB-related stigma is has a huge impact on progression along the cascade. How, where, and who it's impacting is still a black box to us. Yep.
Can you go back to your cascade? I'm just, because the second presentation that or the second couple of studies that you presented on were about identification of cases and getting people into care. But the first one that you started with, the qualitative, was about retaining people in care, right? So I'm trying to remember, like, where is really the biggest issue in South Africa? Is it this identification? I mean, I know neither of them are good, but like, where's the true issue? There was the treatment that gets got.
Oh, okay.
No, but I guess overall.
So you're talking about the TB cascade?
Yeah. So this is
Well,
your study though.
Well, yeah, but I mean, you can think about this still as the TB cascade. So this is obviously the screening and testing cascade, then initiating on treatment and the treatment cascade. So you're asking where?
So I'm not seeing the other end of it. So my understanding with TB is, part of it is these two huge issues that you worked on, which is that you need to identify people and get them started, but then the people don't stay on treatment.
Right.
That because you talked about that at the beginning, people, it makes you feel sick. It's really hard to sustain the therapies. Although there are better therapies, I think, coming out now, right? But yeah, that's a big problem. So, and that is what you worked on with the qualitative, is trying to come up with these peer support, right? But I'm just wondering, compared, like, between those two, like getting people started and then the drop off and the retention, which is really the priority in South Africa, which is the bigger issue.
Oh, so let me just make sure I'm understanding. So what's the bigger issue? The missed cases?
That ends on initiation.
Right.
But if you looked across and you looked at retention and care. Retention and treatment,
So we are looking at that. Okay, so if you're thinking about the TB cascade,
yeah,
about 30% of cases are just missed by the health system. So the magnitude of missed cases and the gap is huge.
Okay.
But even taking that into consideration, there was a TB cascade paper that came out a few years ago. I want to say that still about 30% of individuals still are not successfully completing treatment. So whether that means treatment failure, loss from care, or other issues in the cascade. As I mentioned earlier, about 50% total of all estimated number of TB cases do not successfully complete treatment, with the aggregate being not found, not initiated, not completing treatment. Is that kind of answering?
Yeah, I think so. I think it's
Okay.
both pieces that are almost equally a problem, but the identification of cases seems like the biggest problem.
Yeah, that's a humongous problem. Yeah, the cascade work that was done before said that only 5% of individuals aren't diagnosed. Let me just say that there were a lot of government people on from the Department of Health on that, and the number have a good gossip was much higher, but it was sort of massaged a little to make it look like only 5%. And even if you assume that that 5% of an individual never getting diagnosed is true, the length of time from when they start having TB symptoms to when they're actually diagnosed, we've seen individuals a year and a half with a cough who don't get initiated on treatment. So yeah, you might find that person at some point, but the length of time that they're continuing to transmit is so huge that that's the delay in diagnosis is a huge problem.
Sorry, we'll keep taking questions in the room, but we have reached 1 o'clock. We're a little over 1 o'clock, so I want to go ahead and close out for our Zoom participants. Thank you so much for joining. If you have